Halloween. This is my favorite holiday, so I'm pretty excited. And this is a pumpkin that I carved at a friend's party, and I actually forgot to bring candles with me, so that's my iPhone with my flashlight app in there, but it works pretty well. So I was pretty excited about that. And as well, I brought some candy for everybody. I don't know if you guys have seen these before, but I used to have them a lot when I was a kid. They kind of remind me of anthrax because they have like powdered sugar in it. Anyways, they're like little cigarettes, and if you puff on them, little like sugar comes out. So I think there's enough for everybody to have one if you guys know.
I can't believe that either.
The gum's not great, but it's more just fun to smoke it. And it's probably not a great thing for kids, but I didn't use them as a kid and I don't smoke, so it's okay. Okay, so by the end of this talk, I hope that you will be able to describe the pathogenesis of Bacillus anthracis and what makes it a potent bioweapon in the use of bioterrorist activity. I hope that you can, after this talk, outline the progression and the presentation of the two most common forms of anthrax that you'll see. She's having a blast back there. You guys so, yeah, the two most common forms of anthrax infections that you see contracted with bioterrorist forms of anthrax most commonly. You should be able to recognize some of the unique clinical characteristics of inhalation anthrax and how they might be able to help you distinguish inhalation anthrax from other respiratory illnesses with similar presentations. List FDA approved and CDC recommended treatments as well as vaccines for anthrax. And finally, we will interpret some current data regarding treatment with roxibacumab for inhalation anthrax. It's a monoclonal antibody with an interesting mechanism of action that we'll look at a clinical trial study for. So to start, Bacillus anthracis, the bacteria that causes anthrax, is named from the Greek word anthracus, which is Greek for cold, and that is generally attributed to the most hallmark sign of cutaneous anthrax, which is the form of a black eschar at the site of infection. So black as coal kind of indicates the infection of Bacillus anthracis in the skin. It's naturally occurring, and it is gram-positive aerobic spore forming, which is important to note because it makes it a very potent bacteria. And it's also not mobile. It has no flagella on the bacteria. And in these two pictures, you can see one of the articles I read described it as looking like jointed bamboo rod. So this is a picture of bamboo, and then this is the Bacillus anthracis here. So it has that kind of square end and a jointed sort of train type organization to it. So that's how I kind of remembered what it looks like in the gram stain. It's commonly found in the soil, and historically it is associated with infections of herbivores like sheep and people that work closely with those types of animals. So people in wool sorting factories. In England it was called wool sorters disease. And the bacteria does not survive well outside of the host, so it's really the spores that are transmitting the disease state. And the bacteria will begin to form spores when it has exhausted all of its local nutrients, and it can survive for years in spore form before it germinates and becomes active growing bacteria. And it begins to germinate when it's presented with a nutrient-rich environment like blood or tissue of the host, whether it's an animal or a human. And other characteristics that make Bacillus anthracis a good for a bioweapon is its bacterial capsule, which you can see outlined in this picture here. Both of them, one of them is a fluorescence with an antibody that attaches to the capsule and only fluoresces when it makes that attachment. And the other one is an India ink stain of the capsule and the bacteria itself. So the capsule prevents phagocytosis and increases the virulence of the bacteria. And it also produces exotoxins, 3 in particular, the lethal toxin, edema toxin, and the protective antigen. And what's important to note about these toxins is that the lethal toxin and the edema toxin require binding to the protective antigen for it to be active, but that's done separately. So the lethal toxin will bind with the protective antigen, and then that compound becomes a lethal toxin. And then the edema toxin can also bind with that protective antigen, and it becomes that edema toxin that is active in the body. So protective antigen makes a really great drug target, because by eliminating protective antigen, you're eliminating the efficacy of both toxins by inhibiting that binding. So we'll look at that in the clinical trial later on one of the drugs that is being currently studied to treat anthrax, inhalation anthrax in particular. So anthrax as a weapon. Currently 17 nations are believed to have offensive biological weapons, and Iraq has acknowledged that they have produced and weaponized anthrax. It's odorless and invisible after release, and it can be measured, its range can be measured in kilometers. So we're talking a really wide range that this organism can infect. One of the comparisons that they made was to a hydrogen bomb in one of the articles. They said that 100 kilograms of anthrax spores upwind of Washington, D.C. could cause an estimated 130 to 3 million deaths. So it really speaks to how potent this bacteria is and how it makes a really potentially dangerous weapon. These are 2 instances where anthrax outbreaks have occurred in kind of a relationship to bioterrorism. The first one in Sverdlovsk, Russia, it occurred in 1979. It wasn't necessarily an attack, but it did occur at a bioweapons facility. So it is still a link to the danger of working with this substance as a potential bioweapon. So they accidentally released an aerosolized form of the spores, and there were 79 cases and 68 deaths, and they even found livestock up to 50 kilometers away infected with this aerosolized species. So definitely very dangerous, and even an accident can cause tragic results. And as many of you may know, there was also some isolated cases in 2001 in America where anthrax was delivered through the mail, and there were 22 suspected cases. And this is where we draw a lot of our information about inhalation anthrax in particular. There aren't a lot of studies that can really investigate this particular infection, so we have to work with what we have, which is fortunate that there's only 11 or 12 really solid cases, but at the same time it gives us limited data to work with. So what are the common routes of infection? There are 3 routes of infection: gastrointestinal, cutaneous, and inhalational, but I won't talk about GI in anthrax infections today, because it's really not as common as the other 2 in terms of infection with a bioweapon, because people usually don't ingest their mail or anything, so where they would be more likely to inhale the substance rather than eat it. So not as relevant for this particular discussion. So for cutaneous anthrax, the spores enter broken skin, and they begin to germinate, and they produce toxins. And as you might imagine, the lethal toxin will cause tissue necrosis, and the edema toxin will cause local edema at the site of infection. And if the growth is left unchecked, it can lead to bacterial infection of the blood, as well as some other systemic results like infection of the lymph nodes. And here are two images of cutaneous anthrax infections. This top one is, I believe, after 7 days, a lesion on the forearm. And this is an eschar on the neck after 15 days. It's in one of its last stages before forming that black eschar and resolving itself. So clinical presentation, it will start originally as a pruritic, macule, or papule, and then it will turn into a vesicle and then may have a clear or serosanguinous discharge associated with it. And not long after that, a black eschar will form and local edema will occur. And the ulcer formation, there's actually an ulcer formation step that occurs it's a phase in between the vesicle and the black eschar. It's a formation of an ulcer. And that's in about the 2nd day after infection. And the eschar will fall off after 1 to 2 weeks, and it usually doesn't leave a permanent scar. And additionally, antibiotics haven't been shown to really change this course of the infection. This eschar will still form and fall off, but treating this with antibiotics will lessen the chance that the patient will get a systemic infection or some other more serious infection leading to more serious consequences. Inhalation anthrax occurs when spores are inhaled and deposited into the alveoli, and macrophages then ingest the spores and transport them to the lymph nodes. And the capsules of the bacteria inhibit that phagocytosis oftentimes. The macrophages do successfully phagocytose some of the bacteria, but a lot of them will continue on as spores into the mediastinal lymph nodes, which are the ones in your chest area, right in the center of your lungs. And the spores will sit there in your lymph nodes for up to 60 days before germinating. So it could germinate in 2 days and it could germinate in 50 days. So that's something really important to consider when we talk about treatment methods for this particular infection, because we need to be aware that even if the patient is not presenting the symptoms, there still may be spores that have yet to germinate in the lymph nodes. So once germination occurs, disease rapidly follows, and bacteria will then enter the blood. And untreated, this infection usually results in a mortality of almost 100%. It's extremely lethal, and there are a lot of different clinical presentations that make this particular infection very dangerous. And as I actually didn't mention before, when the bacteria begin to germinate again from the spore form into the bacteria form, it will begin to produce toxins, and then that will continue to cause necrosis and edema based on the toxin release. And another important thing to note is that even once the toxin production has reached a critical threshold, death can occur even if sterility of the blood is achieved. So the toxins are really one of the main driving factors of this disease state. So for clinical presentation, it usually starts, the first stage is pretty nonspecific: cough, trouble breathing, headache, weakness, and then some patients may actually experience a period of recovery. It appears that they are getting better before the stage 2 ends up coming in to play. And it comes in fairly abruptly, and it usually is very severe. So the patient will present with a sudden fever, increased dyspnea, and the diaphoresis they described as drenching sweat. So it's a very significant symptom. And one of the most hallmark symptoms, I think, of this presentation of anthrax is the widening of the mediastinal, which is in the pleural cavity. So you can see these arrowheads here kind of point out the widening of that area, and that's from the swelling that's occurring from the toxin release that the bacteria in that lymph node are releasing. So continuing through stage 2, you may even see lymphadenopathy and cyanosis, hypertension, shock, and death usually follows closely after the beginning of severe respiratory distress. Additionally, because this infection can become a blood infection, this can also cause meningitis. So you might be looking in the patient for delirium or confusion, and that's an important consideration to make as well when we are looking at prophylactically preventing meningitis or simultaneously treating inhalation anthrax that has also caused meningitis. And you can see that a lot of these symptoms overlap with other respiratory diseases. So it's important to look at some potential ways of identifying it and distinguishing it from something like influenza or community-acquired pneumonia. So one of the first ways that we can identify this bacteria is through laboratory methods. So we have an ELISA method, which is effective but not clinically available. So it's a lot harder to utilize this method when we need a quick diagnosis that can give the patient a quick treatment and better treatment outcomes subsequently. So the most often used diagnosis is the standard blood culture. And you can see here, this is actually the blood stain of a rhesus monkey. And it shows the gram-positive bacteria in that stain. And you can see growth from between 6 and 24 hours, which helps, but one of the important things to note about this is that just because we can see growth, it doesn't mean we can differentiate the bacillus species. So you have to, you may have to let the lab know that they need to further differentiate whether it's Bacillus cereus, or Bacillus anthracis, so that we can further narrow the treatment and make sure that the patient is getting exactly what they need. So something to consider as well when you're ordering that. So if you didn't even have a suspicion that the patient might have anthrax, then if you didn't ask the lab to specify, you may not find out after that first test. Sputum cultures for inhalation anthrax aren't very indicative of disease, and you usually can't get a good gram stain out of them because there's really not a mnemonic process to that. So you really won't see a lot of presentation in the sputum culture. And additionally, you can also identify this post-mortem, which you can see in, most notably, as I said, in the chest x-ray, you can see the widening of the mediastinum.
I'm sorry to interrupt this. Banal Patel? No. It's a Banal Patel? No? Okay, thank you. Sorry.
No, it's okay. So, as you can see on the chest x-ray, there's a widening of the mediastinum, and on post-mortem examination, you'll see hemorrhagic necrotizing mediastinitis, as well as some necrotizing lymphadenitis. So ideally, we would like to identify inhalation anthrax in patients before the post-mortem analysis. So what I did was I looked briefly, I'm just going to talk briefly into one of these studies, and it analyzed the clinical features of inhalation anthrax and some other presentations of commonly acquired respiratory illnesses that may be confused with each other. So they took the 11 known cases of IA, inhalation anthrax, and compared the symptoms and lab values for each patient to 2 other common causes of respiratory illnesses. So there are some limitations to this study. It was retrospective, so they went back to a trial that GlaxoSmithKline had conducted for an influenza drug, and they looked at that population of patients that had been diagnosed with influenza-like illness. and they looked at a different study that had analyzed community-acquired pneumonia patients. So they took all of that data retrospectively and all of the clinical symptoms and laboratory results that they received for each of those patients, and then compared it with what they had for the inhalation anthrax patients to see if they found any significant differences or something that might set IA apart and make it easier to diagnose clinically. And the way that they did this was they created a scoring system to sort of an algorithm for you to score the patient based on some notable symptoms they had that had strong associations with IA, but not with the other drug or the other illness that they were comparing it with, to see if they could create an algorithm with high specificity and high sensitivity. So the IA patients had been laboratory confirmed with infection. The ILI patients, that stands for influenza-like illness, had a lab test confirming influenza, fever, as well as 2 other symptoms: headache, myalgias, cough, or sore throat. And then the community-acquired pneumonia patients had the Q-CAP confirmed with chest radiography and blood cultures. And the sample sizes are pretty large, so though it is a retrospective study, they are looking at a lot of different patients, so that does help bring some more solidity to the paper. So this first scoring algorithm is differentiating IA from ILI, and what they found was stronger associations with some symptoms than others, so they changed the scoring accordingly. So they found that IA patients more likely had low serum albumin levels, tachycardia, and lack of nasal symptoms, as opposed to ILI patients. So if a patient presented with low serum albumin, they would get 2 points. If they had tachycardia, they would get another 2 points. And then these symptoms had a weaker association with IA, but still enough for them to use in their algorithm. So if they had something like low serum sodium, they might get 1 point for that. And what they found was that with a score of 4 or more, they could isolate all 11 IA patients with 100% specificity, or 100% sensitivity rather, and 96% specificity. So they were able to get some pretty strong results in as far as this comparison goes between IA and ILI. Does that make sense? Anybody have questions so far about how that works? And maybe just as a reminder, sensitivity is a measurement of the proportion of actual positives that are correctly identified, and sensitivity, or that's the sensitivity rather, I think I may have misspoke. And the specificity is the number of negatives that are correctly identified as not having the disease. So they next compared IA with community-acquired pneumonia and found that it was much more difficult to find strong associations with symptoms only occurring in only in one disease state. So in this case, they had 5 symptoms: elevated serum ALT and AST, low serum sodium, normal white blood count, nausea, vomiting, and tachycardia, and each of those scored 1 point. So in this particular scoring algorithm, a score of 3 or more captured all 11 IA patients with 82% sensitivity and 81% specificity. So they were able to differentiate IA from CAP, but not as strongly as they could between IA and ILI. So what we can kind of gather from this study is that it is a lot easier to differentiate IA from ILI, and with high specificity and sensitivity. However, the clinical features of community-acquired pneumonia and IA are both septic processes, so they have a lot of overlapping symptoms, and it's a lot harder to differentiate with high sensitivity and specificity, which is which through that algorithm. So essentially, we can't put a lot of weight into this particular method of diagnosis, but it is a useful tool that we can use in conjunction with other factors to diagnose a patient with IA. So we've talked about presentation and clinical differentiation, so let's talk about how we're going to treat it. There are a number of FDA approved treatments. Doxycycline and penicillin G-procaine are approved for all anthrax forms, including post-exposure IA. And ciprofloxacin and levofloxacin are approved for IA after exposure. And as well, although it's not FDA approved for this indication, amoxicillin is CDC recommended if in fact Cipro and Doxy are both contraindicated and that the strain is proven to be penicillin sensitive. And the prophylactic therapy dose for the amoxicillin treatment would be 500 milligrams by mouth TID for 60 days. This is something they released shortly after the attacks in 2001. And it's a recommendation for post-exposure prophylaxis for IA. So this would be for any employee of a mailroom that may have been exposed to one of the particular envelopes containing the anthrax. So they may have contracted the spores into their lungs, but they may not be presenting the symptoms, so it would be considered a prophylactic effort to prevent them from presenting with IA. So they recommend 60 days. Again, that's how long the spore can last in there and in the mediastinal before germinating. So trying to get rid of as much of the bacteria as possible and not leaving in any of that space by shortening the therapy length. So 60 days of oral antimicrobial therapy in combination with a 3-dose series of anthrax vaccine. And so for adults, and that's including pregnant women, it's Cipro 500 by mouth twice a day, or doxycycline 100 milligrams by mouth twice a day. And again, those are both for 60 days, and they're both considered equivalent, but there are other factors to consider before you decide on one of the two for a treatment regimen. There are some considerations for children, which I don't think I'll have time to go into, but I have a little bit more information about that if anybody has questions. So some treatment considerations. First, if we're treating anthrax at all, especially something like inhalation anthrax, rapid treatment is the best way to go. So the sooner we can get the antibiotic on board, the better. And another thing to consider when we're establishing treatment is resistance. So a lot of Bacillus anthracis series species have some natural beta-lactam resistance, and they have been found to have carbapenemase. I believe carbapenemase and penicillinase were in the 2001 strain. So there's some natural resistance there, so we would obviously want to avoid that. And resistance can also be induced in these organisms, so it's something else to consider as well when we're initiating therapy. Some other things, if the disease is severe and systemic, or if there's bacteremia, IV ciprofloxacin is the drug of choice over doxycycline. And that's for a couple of reasons, mostly kinetic. So fluoroquinolones are considered bactericidal, whereas tetracyclines are only bacteriostatic. So that would be one of the first reasons we would go with probably ciprofloxacin. Additionally, ciprofloxacin has better concentration in the CNS, especially in inflamed meninges. So that's an important thing to consider as well. If we're treating IA with meningitis, or we're trying to prevent that fact, that's something to consider as well. Additionally, they also recommend adding one or more agents with Bacillus anthracis coverage that also have adequate CNS penetration. They mentioned clindamycin because inhibiting protein synthesis may inhibit the production of the bacterial toxins. And as with other similar clinical disease states, they recommend pleural fluid drainage, which I think they do that for empyema and complicated pneumonia. So just another method of treating this patient and giving them the best chance at good outcomes. And there's a typo here. I wrote switch from oral to IV when appropriate, but I meant switch from IV to oral as appropriate. So just important to note, if the bacterial infection is not serious, then PO is an acceptable formulation to use. So there's one vaccination, and it's the only way to effectively prevent pre-exposure infection. And it's a 6-dose intramuscular vaccine, and currently they're really only administered to military personnel that are going into high-risk areas of the world that may be encountering bioweapon or bioterrorist anthrax. And although it's not FDA approved, they have found that using the vaccination in combination with the antibiotic can help with the treatment outcomes. They compared it to the rabies vaccine. So when you are diagnosed with rabies, you're given the vaccine as well as antibiotic therapy. And they feel that it gives you time to elicit the active immunity while the antibiotic is treating that acute infection. So giving the vaccination wouldn't give you immediate protection from the organism, but over time, given that ability for the immune system to build up antibodies to that particular infection, it would be beneficial to have both going at the same time. Finally, I'm going to look into a little bit a study of roxibacumab, which is a monoclonal antibody in clinical trials for the treatment of inhalation anthrax. So they did a number of studies in here, so I tried to pick out a few that I felt were relevant and spoke the loudest to me anyways. And so it was an open label, parallel group, randomized, placebo-controlled study, and they basically examined the prophylactic efficacy and the post-exposure efficacy of this drug to treat IA in rabbits and monkeys, and they also conducted a safety study in humans. So as I said before, monoclonal antibody, and it's against the protective antigen, so that one toxin protein that binds the lethal toxin and the edema toxin to elicit toxin effect. So by knocking this out, we're getting rid of toxin production. And it has been shown to inhibit toxin-mediated cell death in a rat model. So for the first prophylactic study, they took a group of rabbits and they dosed them at 1, 5, 10, or 20 milligrams per kilogram subcutaneously, and that was 2 days before they exposed the groups to anthrax. And this is placebo-controlled as well, so they also had placebo groups for each of these treatment arms. And then they also tried a 40 milligram per kilogram IV dose immediately after spore challenge. So instead of giving the rabbits that 2-day pre-exposure treatment, they were treating the rabbits after exposure. And for the monkey dosing, they did 10, 20, or 40 milligrams per kilogram subcutaneously, and those were 2 days before. And they based these dosages on the results from the rabbit study, so that's why the dosing is different, and the administration as well. And so they were all exposed to 100 times the median lethal dose of inhaled spores, and the endpoint was the survival at day 14 for rabbits and day 28 for monkeys. So the first graph illustrates the improved survival rates in rabbits. This solid black line is the placebo. So you can see at day 3, all of the rabbits died. And even with just 1 milligram per kilogram subcutaneously, the treatment at day 3, we have days here on the x-axis and probability of survival on the y. So here at 3 days, when we were looking at 0% probability of placebo. At 1 milligram per kilogram, the survival rate was almost half, almost 50%. And it increased significantly, actually, in a dose-dependent manner. So as the dosages went up, so did the survival rate of the rabbits. And this here, they kind of overlap. You can see 10 and 20 both significantly improved survival outcome, as well as the 40 milligrams per kilogram IV. They're actually 100% survival rate at 14 days. And that was the dose that was actually given immediately after exposure. So in monkeys, we also saw a significant survival increase in each of the treatment arms. So at 6 days, all of the monkeys in the placebo group had died, whereas we were looking at almost 70% survival rate and 90% in the 40 milligram per kilogram dosing. Another study that they conducted was sort of seemed kind of off the cuff. It was just sort of, they wanted to test it, see how it worked out. It wasn't a big part of the paper, but it was something interesting to know. They decided that they would test the 21 monkeys that survived 1 year after their exposure to anthrax. And they took 6 monkeys that had not been exposed and exposed all of them to 100 times the median lethal dose. So at 28 days, all of the monkeys that had been treated a year ago for their inhalation infection, pre-exposure inhalation dosing, they had all survived at 28 days, whereas the placebo monkeys, as was indicated in the other studies, had all died. So there was not, I didn't think that there was significant data for this particular study to put all your eggs in one basket on, I guess you could say. But it is something to know, something interesting that can be investigated in the future with maybe larger populations. Next, they experimented with the therapeutic efficacy, and they used rabbits and monkeys again. And they actually challenged them this time with 200 times the median lethal dose. And they gave them either 20 or 40 milligrams per kilogram IV bolus. But these were administered after the detection of protective antigen in the serum. So they exposed the animals to the anthrax and then tested the serum until they found protective antigen in the serum. And when that occurred, they either gave them a 20 or 40 milligram per kilogram IV bolus dose. And additionally, for the monkeys, they only detected protective antigen and then administered. But for rabbits, they either detected the protective antigen in the serum or saw an increase in body temperature of 1.1 degrees Celsius. Does that make sense? So there were 2 different tests that they administered for rabbits to determine when they were going to dose them on the drug. So it was either an increase in the baseline temperature or detection of the protective antigen, whereas in the monkeys, they only detected the antigen, and once that was detected, they administered the drug. And again, here they were studying the survival time at day 14 for rabbits and day 28 for monkeys. So again, we can see that survival was improved in both treatment arms, both the 20 milligram per kilogram and the 40 in the rabbits, and that's over placebo. And additionally, in the monkeys, a similar outcome was observed. Both significant increases in survival rate in comparison to the placebo. And finally, they wanted to study the safety of this drug in humans. So they obviously weren't going to expose humans to anthrax and see if it worked. We were just going to look at an adverse event profile and see if there were any significant issues in administering this to healthy human beings. So they just wanted to determine the safety and tolerability of a 40 milligram per kilogram IV dose. There was one report of a serious adverse event, which was cholecystitis, that they said it could have been linked to the drug, but was most likely due to some underlying condition. So something to be noted, but more research would need to be done to make that a definitive adverse event that was associated with this drug. Additionally, most of the events were transient and mild to moderate, and there was no significant difference between the adverse events seen in the placebo from the adverse events seen in the raxibacumab study group. One thing I wanted to note about this, this is the table that outlines the number of adverse events for the placebo group and the raxibacumab group, and then the number of adverse events observed in 2% or more of the subjects. So the usual culprits, headache, nausea, pruritus, cough, upper respiratory tract infection was another one of those adverse events seen in both groups. But one of the things I wanted to note that the paper didn't really mention at all was some of these patients were also treated in combination with ciprofloxacin. So they didn't really say if it was for some other therapy or if it was for, they didn't mention at all that it was part of the study that they were going to test them in combination. But it's interesting to note that they were both used together and there weren't any significant interactions that popped up in the study. But I would think that continuing on with this, we would need to study the safety of that patient without them being on something such as ciprofloxacin. So it's just something to note that I thought was a little bit strange that I just wanted to point out. So basically in this study, we saw that prophylaxis in monkeys and rabbits significantly increased their survival after exposure to anthrax, inhalation anthrax. Re-exposure protection was seen in monkeys. It was a small study, but it was an interesting find nonetheless. And protection from the drug, if given after the appearance of protective antigen in the serum, did also increase survival rates. So another interesting fact there, as well as the adverse events that we talked about. So, in conclusion, Bacillus anthracis is a very virulent, gram-positive bacteria with spores that can endure harsh environments, which makes it an ideal candidate for use as a bioweapon. Cutaneous and inhalation anthrax are the two most common routes of infection that you'll find in bioterrorist attacks. As well, inhalation anthrax presents like other respiratory illnesses. However, there are distinguishing characteristics that we can use to help us differentiate between the two, between the different illnesses. Ciprofloxacin, 500 milligrams by mouth twice a day for 60 days is the treatment of choice for anthrax, and that's all forms, especially if you're prophylaxing the patient post-exposure. And finally, raxibacumab has shown increased survival in rabbit and monkeys exposed to aerosolized B. anthracis spores and has demonstrated safety in humans. So hopefully what we've gone over today will help you to answer each of these objectives or to feel confident in assessing yourselves in each of these objectives. These are my references and my photo sources. And this is my carved pumpkin after 2 days outside, so kind of looks like a guy without his dentures, but I didn't really consider the lack of support after I carved that massive, mouth in his face. So I just thought it was a funny way to end this Halloween talk, I guess. So, any questions? What questions do you have for me? Was I unclear on anything? Go ahead, Megan.
With the 60-day treatment period, were there compliance issues? Was that stated anywhere?
It wasn't discussed. There's definitely going to be compliance issues with the 60-day treatment regimen. but I can only hope that with the patient understanding the severity of the potential illness they could contract, that it may help their compliance. And I think that the first event of attacks was scary enough, and I think they would probably be really, adherent to their medications. So that wasn't discussed, but it's a great point. It's definitely something to consider with such a long treatment. And I actually didn't mention that before, but a lot of the antibiotics aren't used for that length of treatment time. So some of the adverse events may be more severe in that long treatment duration. So it's just something to consider as well when we're doing those long-term therapies. They haven't been investigated maybe past 30 days for some, so we don't really know what to expect, but we hope that the benefit outweighs the risks. Alex?
What kind of facilities do you need to manufacture this weaponized grade?
That's a fantastic question. I did not look specifically into the manufacturing or the requirements. I do know that the spores are really easy to grow. They don't take a lot. They're not hard to, you can freeze dry them. Some of the stuff I was reading was just kind of awful. The way it was almost like an advertisement. Well, oh, you can freeze dry it. You can, mill it. You can put it into a powder. You can put it into a bomb that explodes, and you can shoot it as an ammunition. It's just, there are a lot of different ways that you could utilize the spores. So I imagine that as far as maintaining it, it would be easy to grow, but I think that you would obviously have to have a lot of security and take precautions to prevent events like the one that happened in Russia in the 70s. So does that answer your question? Or?
Well, I was asking because I remember back during that whole debacle back in '01 that one of the key points about it was that in order to produce an anthrax, a weaponized grade, was you needed to make it fine enough that it could be inhaled.
Mm-hmm.
Too much, if it's too porous, it basically may be causing GI infection.
Yep.
And very low mortality by comparison.
And that is a great point too. I did read a little bit. I have an article too, actually, that I can send you if you're interested in. It was published in the. I hadn't heard of the journal before, but I can pull it up. But it was a study that just kind of mentioned the ways that you can make the spore more virulent or more easily transmitted, and that was one of the ways, by micronizing the spores and making sure they're really small and easily transmitted through the air so that they can be, inhaled by the maximum amount of victims, I guess. It's kind of a morbid analysis, but I think that is a really good point. It's one of the ways that they have to make it transmittable to the maximum number of people. Does that make sense?
Yeah.
I was going to see if I could pull that up.
Did you see a number for the ID50?
We did. But I don't know it off the top of my head. I can pull that information up, but I don't.
No, that's fine. I was just curious if it was like, if I inhaled one spore, would I?
Oh, I think that one I saw was, I want to say it was 40, but I need to look that up. I should know that, but I'm sorry.
Oh, no.
It's a great question.
That's fine. And then in terms of the livestock, is the disease as deadly when like the sheep are infected? I already mentioned.
Do you mean deadly in humans?
No, deadly to the sheep. Like, do they just carry it living?
And actually, in 1945, there was an epidemic in Iran, and there were 1 million sheep that were killed as a result of an anthrax outbreak. So one of the ways they prevent that is actually vaccinating the animals. So they do have a vaccination which prevents them from contracting the disease after ingesting the spores that are in the soil in the areas where they graze. So kind of helps, but still, actually that chest x-ray I had was of an actual occupational inhalation anthrax exposure. So it was actually somebody who worked in a wool factory that had contracted that disease. So it still occurs even with the vaccination, but it does help to lower the transmission that way.
Also, the inhalation anthrax, isn't that non-contagious?
It is not contagious person to person.
Yeah.
But it would be more, you know, if you had a sheep that had a lot of, you know, spores from the dirt it was rolling around in, and then you were, you know, combing through, you know, tons and tons of wool every day, you'd be breathing in probably enough spores to contract that.
Yeah.
But as far as transmitting it to other people, that's one thing that is good about anthrax, is it can be used to cause an epidemic in terms of transmitting it from person to person. So, but one thing I did note is that the spores can begin to form from bacteria when exposed fluid, infected fluid rather, is actually exposed to air. So, you know, if you had an exposed patient that had blood, you know, had some sort of like bleeding event, then the infected blood might start to form spores, and then that would be another way of not necessarily transmitting it, but I mean, the spore formation is easily accomplished, and it can be, even from a patient that's been infected, spores can form and then potentially, you know, give an opportunity to transmit further infection. So I think one of the important things they talked about was taking care of the body afterwards, so autoclaving all of the, you know, post-mortem tools used in the autopsy, or discouraging people from embalming and preferring, you know, something like cremation. And so a lot of other facts to be taken into consideration as far as the elimination of the spores in the patient even after they have passed away. I can take more questions. I was just looking up that article I found.
Excellent overview. Thank you very much for that. I just had 2 quick questions in terms of, I don't know too much about rabbits and monkeys here, but in terms of the difference in follow-up, now the rabbits was 2 weeks and then 28 for the monkeys, so was there a longer incubation period? Did you come across?
I didn't really get any solid answers from that study. I do know that they chose those 2 species because the clinical presentation is similar to humans in both of those, in the monkeys and in the rabbits. I kind of figured that rabbits maybe have shorter lives, so maybe they're, that was just a, you know, guess. I didn't find anything specific. They just mentioned that was how they measured the survival rate.
Okay.
And I do believe they measured survival rates overall as well. So they did go past the 14 days, but that was where they had stopped the initial endpoint. But the survival overall still was significant.
Okay, great. And then just a general question, so considering you mentioned that the drug of choice is ciprofloxacin, and we're going to administer that on a twice-a-day schedule, what would you want to counsel your patients on in terms of potential drug-drug interactions?
Multivitamins and, you know, antacids, stuff like that. I probably make sure that those weren't administered at the same time so that